I was just telling Dr. Spitzer that like I didn't realize that these people were going to RSVP, and I was really excited that they did because I was afraid we kind of organized it almost to the last minute. But thank you all so much for being here. This is our third of our evening lecture series about adults and health, sex, drugs, and rock and roll theory. By the way, just as a plug, if you guys have ideas for future topics, if you'd like to see this in report, please let me know or email one of us. I'm very fortunate to be joined by a very experienced panel today. And everyone's kind of gone through their introductions already, but we have a really great mix of disciplines. We have an advocate from the community, who I'm really happy to have here, Dr. Depp, who in community practice is a psychologist, myself at the UC San Diego system, Adriana Gonzalez, and Dr. DeBloy, I'm sorry, French. I'm Canadian, so from the military system. Active participant in the audience, Elizabeth Sias, who's also a medicine doctor in the Navy system, and then my Marie Rich from. So what we thought we would do, because this is such a rich topic, we really wanted to save as much time as possible for questions and case discussion at the end. So the panelists are each going to give just a very brief 5-minute introduction to kind of their role in providing care for gender identity, and just some definitions, some introductions, just some basic background, and then after that we'll basically just open it up to questions and discussion of interesting pieces. So maybe Dr. Devlin, you could start us off.
So I sent a couple of things in attachment.
I don't know if you can try to get it.
So is that okay?
Is this your first slide? Yes, that's his first slide. And why am I over there? Not you.
See, I do have a handout, I think.
Okay.
So I don't think we have time to go through all these slides, but so you have this with your handouts, just some basic definitions that a lot of you are probably already familiar with, but it kind of gives us jumping off place. I think the things that the definitions that I think are most confusing are just sex and gender. I think people get those a little bit confused. So, sex is just your anatomical being, male or female. The gender is how the person feels it internally and how they sense themselves. When you think of it that way, you go down to the bottom. You can look at your cisgender, transgender, and gender fluid. Kind of gives you some idea about how we look at the different groups. Cisgender is probably the majority of folks whose gender and sex match. Transgender is where the gender does not match the natal sex. And then gender fluid is a more confusing gender description, but it's really those kids or adults who fluctuate in their gender. These are just some pearls that I like to throw out, and when I'm evaluating kids or adults, we see a lot of kids and adults at the Naval Medical Center. We have the transgender care team for the adults who are transitioning from the military, and then we have the gender clinic over in adolescent clinic. So we have quite a few kids and adults. I think the mantra that I like to keep saying is just be affirming and firm. And then I won't go through all of these, but they're little pearls that I give the residents when I'm talking about this topic. But most of all, be humble. If you make a mistake, make sure you apologize and move forward. The next couple of slides look at the definition of gender dysphoria in DSM-5, which is the new psychiatric Bible. And I kind of pulled out the dysphoria. There's sort of two parts to the diagnosis. There's the gender issue, and then there's the dysphoria issue in the DSM-5. In your handout, I kind of go over some of the ideas that I think about when I'm seeing a kid in terms of the dysphoric part. I think a lot of it when DSM-5 came out was the dysphoria over the gender, over the current natal gender and how you don't feel right in your body, versus once kids sort of come out and start working on this, it's more dysphoric to deal with society. So it's also sort of a second layer of dysphoria. And then you can go on to the next one. And then this, I just put up and it's in your handout again, the criteria for gender dysphoria in kids and in adolescents and adults. There's two sections in terms of the part A. DSM is everybody familiar with DSM? Yeah, it's very research oriented, and but it gives us a good idea of how we can be talking about the same person. So in the evaluation, so once I'm sort of, when I see kids or adults, kids who are coming in with this issue that they're transgender, usually say, that they're coming in. If you have a kid that's maybe LGB, they oftentimes don't come in for LGB issues. It's usually depression or anxiety, and then that comes up in the session. But kids who are transgender and adults who are transgender, they really do know what they want, and they come in, and that's what they're there for, essentially. And we see a lot of kids who, maybe you have kids whose parents are very supportive, and they come in, the parents are on board, we're all talking, it's very clean, versus the kids who come in with parents who maybe don't even know, or they don't want to know, or are plain out rejecting. And those are a little bit more difficult to evaluate because of a lot of privacy issues. And if we do have to use medications, we need to get the parents on board too as well in terms of the psychiatric component. But I focus on the history, and I don't call it the history of present illness, I call it the history of presentation when these kids come in, and focus on kind of what is it that they look at in terms of what they want to do in terms of transition. Is it just hormones? Is it just the legal part, name and gender changes? Is it surgical? So is it the gender affirming surgery? If I try to get an idea of where they want to go so I can get the correct people involved. And on our team, we have all sorts, we have the whole gamut of the multidisciplinary team, all the way to plastic surgeons and the urologists and gynecologists. So that's one of the things I try to get right up front, is understand where they want to go. And then I just listen to their story and let them tell me about their story, about growing up in latency years, through middle school and puberty and then high school. And I do the same with adults as well. I try to just let them tell their story, guide them a little bit in terms of the different developmental stages of life. I'm very developmentally oriented, so I kind of go through the different developmental steps. And then in terms of the developmental history, most of these kids, other than the gender development, are, there's not a lot of other issues going on, at least the ones that we deal with. So go straight to the gender development. And again, that's part of the story. And I won't go into all the details. I think in DSM-5, they go into very specific details about toys and play and clothing, etc., to help you understand that they are transgender. And then the last part of my assessment, I look at the psychosocial issues that are really pertinent in this population, where the two. Does everybody know what the two biggest risk factors for these kids in terms of safety and suicide? It has to do with friends and family. So rejection by friends and family is one of the key issues so if you see a transgender kid who's got a lot of that, be careful and be safe with them. And then the other one is drugs and alcohol. So those are the two big risk factors for this population. They have all the other risk factors, and sort of other kids have these risk factors too, but it's big with this population. So I look at the family system. You know, there's a lot of issues in families, as you know, that could make or break how these kids develop. So religious issues, issues around LGBT stuff, conservative versus more open-minded families. I mean, I won't go into that, but you all are experts in the field. And so, I'm doing the next one, and next one. So you have all these slides in here. And then there's a handout here that I will get to parents sometimes. If, I feel it's very, very basic, and it's through the American Academy of Child and Adolescent Psychiatry. And that website has a lot of different handouts for families and kids about lots of different topics. And they're free. All right.
Thank you so much. Dr. Markovich, do you want to?
I can go next, and I really did not prepare a presentation. It's just kind of few slides that can maybe bring up more questions and discussions. And this may work. Okay. So I'll start with a case, and this is a case from my clinic. This was an almost 17-year-old Hispanic teen that came in with patient with named Marco. At that time, patient did not have a preferred name or preferred pronoun. This is something that the scheduling asked them if they wish us to use any different name, and patient did not have name other than given. And the mom was initially the one providing the history, saying, I always remember that he will be gay, and he was gay. And when he was 2 or 3 years old, he really liked girls' toys and would say, I'm a girl. So she said, I knew that he will be gay. Oops. So at age 4 or 5, parents took the child to their pediatrician and said, could you please tell us what's going on? Can you check if he's gay? And pediatrician said, well, I cannot say anything about this child's sexual orientation. What will happen? It's too early. This is only a 5-year-old. And then parents went to see a therapist. And again, they did not get a lot of explanations or answers. And they kind of did not do anything about it. And years went by. And years later, when patient was about 16 and a half, came out as transgender. And parents were very, very surprised. They feel that they're supportive when you talk with mother. She said, you know, I'm supporting, but it's hard to talk to him. He closes up, he's very sensitive. And as the time goes by during the encounter, patient was very shy, but little by little opened up. There was no prior diagnosis of any depression, anxiety, no suicidality. We kind of have a little checkbox that we asked, and nothing was checked. And patient said that it's very hard to talk with her parents, that her dad would say, you will never be a girl. We like you the way, we love you the way you are. Why are you trying to do this? And really could not understand. And again, parents feel that they're very supportive because they tell their child, we love you, don't do this. What are you doing? And then sometime in a visit, she did say, I would like to use pronoun she, and this is the name that I would like to use. So she did open up a little bit. So this case illustrates how difficult it is, and this kind of goes to what Tom was saying, that a lot of providers, let alone families, have struggled with gender, sex, and sexual orientation. And I'm not going to go into definitions because it's available in handouts. But again, reflecting, and you will probably hear very similar stories from both of us. We did not coordinate, but ask and listen, because kids will tell you, teenagers will tell you. And terminology is important. It's a fluid field. Things that we use maybe 2 years ago or 3 years ago may not be as appropriate. I'm always open to learning. I ask my patients, is that okay to use this term? Or if I get feedback from, people who are in the community and tell me, what, this is not appropriate term, I erase it immediately. So be sensitive, be respectful towards the patients and their families. Ask about preferred name and pronoun, and understand that it may change. Like kids may decide, or teens may decide that this name fits them better over time. It does not mean anything about their gender identity. It's just that they find name that fits maybe better. If you make a mistake, apologize. This is so powerful. I'm just saying, I'm sorry, I did not mean to be disrespectful. I did not mean to hurt you. And sometimes even saying that in the very beginning of your visit, I apologize if I make a mistake. I'll try not to. And also your staff should do the same. And be okay that if you make a mistake, you acknowledge it and move on. Understand that there is a spectrum of identities, and trying to push people into box A or B, pink or blue, whatever box we are trying to push people, and it may not work for everybody. And there are people who may be fluid, may identify as non-binary, and putting them into any sort of agenda is wrong. And assuming anything is wrong. And just simply ask. And I start my visits with what brings you here today, because it is very different for different families. And oftentimes I don't have a luxury of knowing much before the patient comes in, and sometimes I'm not sure what they're going to ask for. And so be sort of open. Each patient have their individual needs, and they may be very different from what we can assume that their needs are. Their desires and preferences may change. They may learn more about themselves and be okay with that. Again, allow space for fluidity and for exploration. Educate families. A lot of time, families are not there yet. They're not ready to move on with any treatment. They're here to learn from you very, very basic things, and they're very fearful and scared. And I see a lot of tears in the office because people are really, really scared. Teens are scared what parents would say. Sometimes they don't verbalize what they feel, and they hope that somehow in this environment with you backing them up a little bit, they would be able to say what they feel. I cannot tell you how many times I heard the phrase, it's a phase, and I know my kid is influenced by YouTube, or they have a friend and they've seen another kid on TV and that's what they want to do. It's very unlikely that you are choosing this difficult path just to follow your friend. But it is very oftentimes we hear this. And we have to respect parents and acknowledge their fears, and then going back to educate. This is how they understand what's going on. And then I just want to make a note that people with autism spectrum disorders have their individual feelings about their gender identities, and having autism does not preclude anyone from treatment. What is specific in children and in youth that we cannot do any treatment without parental approval. Both parents have to agree to hormones or procedures. And that can be struggle sometimes. There are cases that parents don't see eye to eye, and it can be really, really difficult. And again, from cases where you're really having one parent very resistant to any sort of treatment, even puberty blockers, I learned that you have to build a bridge. You have to connect with that parent. If you corner one parent and do not let them express their fears or what they are worried about, and you do not try to address those, it will be very hard to move on. And trying to do some legal measures, it's very hard and may harm the child. And going back to support and kids definitely thrive if they have the more love and support and care that will make a difference. In children, we do use pubertal suppression. This is something that may not be used in older adolescents. And there are various treatment options. If you have questions, I can talk about it. Insurance coverage is typically very difficult to get for some of the procedures or some of the treatments that we offer. And several times, numerous times, I've heard from the patients that came out to their pediatrician first. And I just want to acknowledge the power of pediatrician. You know kids really well. You see them for years. You may sense something, and they may open up to you before they open up to their parents. So use this precious, 5 minutes that you have on your well child check to ask simply, have there been ever concerns or questions around your gender identity? If it's a smaller child, ask some of these questions, and they may open up. That may open up conversation with patients or with parents. And I think this is about our center and various services that we offer, but I don't want to take up more time. Other people have opportunity to talk. Okay.
Thank you so much, Dr. Maybe I will ask Adriana if you could talk a little bit about.
Sure. So I'm a licensed clinical social worker at the Navy Hospital. Before this, I've worked with adolescents in a number of different settings across the spectrum. My role at the Navy Hospital is kind of numerous. So I'm embedded in 2 different clinics. I'm in the pediatric clinic at Balboa Hospital, but I'm also attached to the adolescent clinic over at St. Loma. And so a lot of times we find that these kiddos get referred to us in different ways. So either they're in the primary care doctor's office doing a regular well child check, or they're at the adolescent clinic for a sports physical, and will then kind of drop this bomb. And so the providers are like, oh, what do I do? And so then that's when social work kind of gets involved. And so if it's a provider who's not comfortable, working with this population, or, they just don't know the appropriate next steps, that's kind of where my role will come in. And so they ask me to come in and be able to support however I can. I'm also part of the adolescent gender clinic. So we started this clinic about 1.5 years ago now, because we kept seeing an increase of these patients coming in our primary care clinics. The doctors just kind of automatically deferring to adolescent medicine because they have the magic wand and they should know how to fix it. But I'm also attached to adolescent clinic, and so they were like, oh shoot, so how do we do this? So as a team, we all got together and decided that we're going to do the best that we can for these children. So we started our gender clinic, and so it includes social work, adolescent medicine, pediatric endocrinology, and our child adolescent psychiatric doctors, so our team there. And so we get together twice a month to be able to provide services for these children. The clinic's name has kind of gotten out a bit because we do have military resident doctors kind of rotating through as well. And so they kind of know our work and what we're doing, and the word is kind of getting out a little bit. So if a family or an adolescent has been referred to me because they just disclosed in their primary care doctor visit, my role is to kind of go in and provide whatever support services that I can. And sometimes it's very much figuring out, okay, what are we working with here? Are we out? Are we not out? Does family know? Do they not know? What is the stance here? As far for the gender clinic, they've been referred to us by somebody. So at some point in time, they've disclosed this information with or without their parents, and have been referred to us in order to be able to coordinate the care. And so our goal is to be able to provide that kind of one-stop shop of all the different services for these children and for their parents. Sometimes they've come to us. My role there is more of like kind of care coordination, clinical support as much as possible. I'm very, very fortunate that we do have our psychiatrists on our team, though, because they are definitely more the experts. We do defer to them for a lot of different things. But as a kind of the care coordinating role, my job is from onset, we get that initial referral. And my job is to kind of get as much history and information as possible so that we know that this is an appropriate referral, so that we know, this child and this family's history and background, especially from a mental health perspective, because we need to know, are they well supported? If they're not, then that way I'm prepared to refer to our team or to refer to the experts in the community to be able to provide ongoing mental health care. A lot of times it can be challenging because, they may be younger than 18, they are still dependent youth, but, the number in our system is their parent's cell phone number. And so the first person I get on the phone is their parent. And if they've been referred to our clinic, a lot of times they kind of know that they've been referred, they kind of know what's going on. Some of these kiddos have already started care out in the community, have already been receiving ongoing care, and for whatever reason felt that it was a good opportunity to transition to the transgender care team. Sometimes they've received no care, and so that's kind of where our team comes into play as well, is wherever this child or adolescent is in their transition process is where we are working with. So we're trying to figure out, what are your goals? Where have we come so far? What is it that you like to do? We're very, very conscientious about the family support piece. My job from the beginning is making sure that we can get a feel for how the parents are feeling, where they're standing, what is it that they're hoping for, what is it that their fears are, to hopefully give them a sense of support as well, and making sure that decisions will be made when we feel that everyone is on the same page here, when we feel that everyone's at least comfortable. We want to do what's best for this child, but we want to make sure that everyone at least feels supported as well. So once they come to our clinic, that's where we again just kind of evaluate, where have you been receiving care before? Do you have a long-standing mental health history? That's not something that's going to disqualify you from receiving services with us. A lot of times they go hand in hand, and we do know that. And we just want to make sure that we're not missing anything else. If they've been receiving care in the community, if they've been in therapy for a long period of time, and that their provider is supportive of transition, then all we ask for is a letter of support from their therapist. And that way, when we come into gender clinic, we meet with the endocrinology team, we can talk about, okay, next steps for starting hormone therapy and things like that. If they've never been seen in the community, they don't have, any kind of mental health care history, then our stance is across the board. Everyone, we want to make sure that you get a really good mental health evaluation. We want to make sure that we're not missing anything. We want to make sure that you're fully supported, and that any other supports that you could possibly need, that you're going to receive that from our team. So I think that was the main points. I do want to really, though, reiterate the importance that both Dr. Markovic and Dr. DuPoy mentioned of just kind of how our encounters with these children and adolescents work, and the importance of just being humble and being genuine. I find that with the parents, especially the ones who are a little bit more resistant, but also with teenagers across the board, this population or not, they smell fake a mile away. So the more genuine that you could possibly be, and humble and open, and just to be able to listen to whatever it is that they have to say, and support as much as possible, but just be truly humble and truly open and honest with them, that you get so much further with them. But I also found that works with our really resistant families and parents as well. True transparency from the beginning, especially with timelines. There's expectations that maybe the parents are resistant, but the kid's ready to go, and they think tomorrow they're going to start everything, and tomorrow they're going to get surgery, and that's not the case. And so just transparency as far as what are realistic expectations. No one's trying to hold you up from anything. We just all want to make sure that this is in your best interest, 100% what's going to be the best for you. So I do want to really reiterate that as well. I think that's super, super important. If you're somebody that is a primary care provider or the original holder of that information, just knowing where your resources lie as a provider, and what resources you have available to you to be able to then provide these families the support is also important. But you're there in the moment, and understanding basic terminology and things like just listening and being supportive can get you a long, long way.
Thanks so much.
Yeah.
So maybe next I'll ask Dr. Depp if she can a little bit about her approach to gender affirming psychological.
Sure. Hi, everybody. A little bit about me. I completed my postdoc at
within the Division of Adolescent Medicine, which is where I met Dr. Kumar. And my specialty focus was the Trans Youth Center. So definitely I got trained kind of in the epicenter of where it was happening. And I didn't realize how lucky I was at that time. So I left and realized, oh wow, not everyone kind of has the same approach. And from there, I moved to San Diego, and I worked for a little bit in North County Health Services, but now I'm currently in private practice in the community. And yeah, my approach is gender affirming care for youth and their families. And I see it in terms of we understand and working with youth, that not only are we working with the youth themselves, but also with their families as well. So I see myself as a navigator and as a bridge a lot of times in terms of interpreting between what the youth is saying and how to translate that in a way that the parents can understand, and how the translate parents are saying so that the youth can understand. And in terms of translating as well, my slant, sort of my tagline is I'm really working at the intersection of gender, culture, and language. So looking at someone's gender identity, right? You guys heard of the concept of intersectionality? So a little bit of intersectionality is really understanding everyone, we all have multiple identities, who we are, how we identify. And a lot of times our multiple identities, they intersect, and they can sometimes reflect and add more potential psychosocial stressors to the individual, but also looking from a strengths-based perspective of a lot of resiliency and strength as well. And so looking at someone's gender identity is just one piece of when we're looking at an individual and potentially their struggle. And on top of that, looking at their culture, right? Whether it's their racial, ethnic culture, or just every family has different culture as well. And then looking at language. So I also speak Vietnamese and Spanish. And so when I'm working with family, I'm really understanding, a lot of times I literally am translating sometimes for the adolescents, where maybe they speak Spanish, but their Spanish isn't that great. And that their parents are speaking, a Spanish that the kids aren't understanding. And so a lot of times I am literally interpreting and translating for these families, which is in my third language, which is still quite funny sometimes. And that it is the importance of looking at the various identities, right? And I was just kind of thinking about like ability. We look at we're looking at a client who is, transgender, gender non-conforming, but on top of that, they are in a wheelchair, or they have some kind of medical diagnosis. We know that's going to add another layer of stress, right? If you look at someone's, linguistically, we look at someone's legal status, right? Their own legal status, or their family legal status, if they're worried about being deported, that's going to add another layer to understanding their stressors. Socioeconomic status, right? Where they're going to school, is there any bullying going on? Culture, religion, right? What happens if you come from a family that's very religious and you still identify with that religion, and that's part of your life, but you also identify as trans, and maybe part of your religion, your group is telling you that you're going to go to hell because how do you kind of reconcile all of that? And so I think the sort of my takeaway message that I hope that I leave is really understand it is very complex. There's this complexity, but I think there's a beauty in understanding these overlapping factors and how they contribute to and make gender dysphoria even harder for the individual. And that a lot of times anxiety, depression, and anxiety is a result of the gender dysphoria, and how do we tease that, right? So a lot of my teams that I work with, and they're coming in, and I think a lot of times it would be easy to slap an anxiety diagnosis on them, but really understand, okay, so you're anxious because you are not passing, right? I don't really like that expression, but presenting in a way that fits the gender norms. And so being afraid to go to the bathroom. So you can imagine then in terms of holding in, your pee, which is going to lead to UTIs and all the other issues. But then on top of that, the anxiety that they're constantly feeling, how is that going to impact your academics, right? How can you sit and focus on a lecture when, you're worried about going to the bathroom, or you're worried about, oh my gosh, this person's bullying me, right? So I also do psychodiagnostic assessments as well, testing the neuropsychic valves and stuff. So I'm always taking into account all of that before I slap, learning disability diagnosis in terms of my recommendation, for schools and families. And what else? And then I think the other thing too was mentioning that what I've seen in my practice is that now a lot of families are, okay, we get the binary in terms of, all right, my kid wants to transition. Okay, so now they want to be a girl, or now they want to be a boy. But I think what I'm seeing more of a lot of conflict is sort of the non-binary, gender fluid, right? I just brought this book. Have you guys seen The Gender Creative Child by Diane Aaron Fox, who is a leading psychologist and front end working with gender creative, gender expansive children. I'm not too big a fan of gender non-conforming, but still it is a conforming, right, to societal expectations. And we think, what does a girl do and what does a boy do? So I think too of really understanding that gender is so fluid. And I think our tendency is to want to put people in a box because it's easy, right? It's easy to check that box. You're like, okay, I can. But it is a really understanding that, yeah, in terms of, let's say, this child, I mean, whatever their assigned sex at birth is, can they wear this outfit and just be themselves? And do we have to label and say that, no, you can't do this, or okay, fine, you're going to do this, and we're going to put these different sets on you? And that in terms of too, of looking at the research is slowly changing, understanding, and I just got the New American Psychologist from perusing it last night, and the first article was The Future of Sex and Gender in Psychology, 5 Challenges to the Gender Binary, and really challenging that, yeah, that things just aren't in the binary anymore, and really to be open to that, even though it is going to produce our own countertransference or confusion, and potentially, saying the wrong things. And I always out myself and say, hey, I identify cisgender, I identify heterosexual, I don't have the lived experience. I've been doing this for over 10 years. I'm very passionate about, being an ally, to the community and being very humble. And I think I've definitely mispronounced, and said things that maybe weren't the, most sensitive things in that moment. But I think it is of apologizing and learning, and then, I think being able to have that with her. So that's just a little bit of what I do.
Thank you so much. Kathy, it would be great if you could introduce yourself and your organization.
So I have a son who is transgender. Started his transition 7 years ago, and there were none of you serving those kids 7 years ago, which I just want to take a moment here, because for 7 years I've been committed to getting more medical providers trained and on board to be affirming. And look at this room, right? We do a ton of trainings now, but 7 years ago there was no one. My kid had been seeing mental health providers for years in distress. And I kept saying, there's a gender issue, there's a gender issue. I didn't have the word transgender, and we Googled back then, that didn't come up. And the mental health providers we were working with did not have the word either. And so my son suffered many, many years of extreme distress, self-harm, and suicidation because they were not informed and educated providers. Nothing against them. It's a whole different world 7 years later, right? And this just is amazing to see how many folks are now wanting to serve the population. I came in the time when there wasn't. So my organization started out as a need. There were families who were coming onto this journey shortly after we came on and started calling me. My kids nicknamed me the mom with the big mouth, and she's not very good. Including calling Brady Children's Hospital and saying, I need an appointment for my kid, and then saying, you don't treat that here. And calling back 5, 6, 7, 8 times to get them to see my son, right? And so as families started coming on board and needing more help, and helping in medical departments, helping in education at their schools, and just helping understand the process, we ended up turning this into a nonprofit organization. We have served over 600 families so far. I think one of the biggest pieces that we offer is we actually go into families' homes and sit with them in their living room or across their kitchen table and help the parents to understand what this journey is like. Some of those times, we are actually there when the child comes out, because we do a lot of outreach in schools, so kids don't have to walk through that piece by themselves. We refer to all these people sitting around the table here constantly, right? So offering those services to families, supporting them. You heard several of these individuals talk about families feel like they're supportive. We like to kind of put it in a 3-step process. So every parent is going to say they're supportive of their child. Every parent wants their child, right? So we can't say they're not supportive. So we could move to accepting. Let's get families to accept it. Accepting using name and pronoun, right? Which is a really big deal and sometimes takes many, many, many different conversations to get them to. And then from accepting, we move into affirming. And affirming looks like, I got you back. I'm going to stand up to grandma. We're going to go call the doctor now. I'm going to go to your school and make sure these things happen. Once they're on affirming, they're on the trajectory, right? And then we also work with their schools. We go in and do transition plans for you so that we're sure that the schools are practicing the laws the way that they're supposed to be. Not all schools are even aware of the laws coming out of California, which is really kind of sad. And we help with insurance problems because the whole insurance field is new. 2013 is when that started. With most insurance plans covering it, the ACA brought that into it, but they don't necessarily do a very good job, in particular around adolescent care. Adult care, it's a little bit easier with the insurance. And then my goal is to eventually not need to be working in my field. That would be the ultimate thing. And so while we're working with families, whatever issues they have that they've come up with, we go out and try and help to change those issues on a broader scale. So making sure that, medical and mental health doctors are on board and that we're growing that field, going into the schools, into training to make sure educators know what the laws are. And we do a lot of collaboration with different services and work with, we've been training at Kaiser for the last couple of months. And when we talk about training, we're talking, from the front end call centers all the way through, because every time a youth comes into a facility, you may be the most affirming professional that they've ever met, but if the person who checks them in uses the wrong name and pronoun, they are done for the day. And it doesn't matter how great of a physician or PA you may be or any of that, if they haven't been honored and respected throughout the process before they get to you, they're not going to be happy with you. It's that simple. So we work a lot with those front-end staff, service reps, that kind of stuff. We trained.
Yeah, we actually just had a class. We're on pronouns, like, okay, how do we fix this process? They don't call Chloe.
Yeah.
So we actually went back and sorry, I'm Rachel Drum from Judy now.
So those are some of the things we do. Lots of behind the scenes to really help kind of push forward for the equality and rights of trans youth. It's trans family counterpart. It's trans family support services. And I do have my cards are over there. This tells you all the services that we provide. We have support groups and all kinds of things, but then also I want to bring your attention to these flyers over there. Gender Odyssey is a gender conference that happens for 14 years in Seattle. We are co-producing this conference and it will be happening in San Diego this year in August. So there's a 2-day professional track and then a 3-day family track. So you can pick those flyers up on the way out.
Kathy, thank you so much. So I guess I'll be last, but the one thing that I want to spend a few minutes chatting a little bit about, and I really appreciate all of the perspectives that our panel has brought today. I think it's so important, and I also think it's great how, we didn't coordinate in advance, but everybody had very, very similar messages for how to approach kids and families. I do not work in a gender-specific clinic. Like many of you, I'm a primary care provider. And so that's kind of the point of view that I guess I'm representing on the panel is, like many of you, I'm sometimes the first person that kids and their parents might be coming to when they're coming out to their families or they're having questions about their gender. So I just want to survey the participants here. Who's had that experience? Okay, so quite a few people here where, I mean, you really are the first point of contact, perhaps, for a family or a kid who's trying to understand this and explore this. One thing that I found really, really useful, and I would encourage you all to have a look at it when you have a chance, is the American Academy of Pediatrics put out a great comprehensive guideline at the end of 2018 about providing gender-affirming care to children and adolescents. It's a great read, and I just wanted to take a few minutes to summarize some of the key points that are in there, because I think it's really practical for primary care pediatric providers. The first thing that they talk a little bit about is they really quantify just how much psychosocial comorbidity gender diverse youth really suffer from. They mentioned one study that I found really scary, that 56% of trans youth versus only 20% of cis youth reported previous suicidal ideation, and 31% of trans youth versus 11% of cis youth had actually attempted suicide. So we're talking about more than 50% of kids thinking about killing themselves, and I mean that's unacceptable, right? And as providers, we really have to take that seriously. But the one really important point that they made, and that Dr. DeBoy made as well, is that there's no evidence that mental health problems or psychosocial comorbidities are directly attributable to having a diverse gender identity. It's not like one equates to the other. And having a diverse gender identity is not considered a mental disorder in and of itself, any more than homosexuality is a mental disorder, you know? And these are some old ideas that we have to start kind of getting away from. The problems happen when you do develop dysphoria. In other words, when struggling to live your life, struggling to function in your relationships, at school, with the things that are important to you, when that gets affected because you can't live authentically, then that's when we're talking about gender dysphoria, and that's where a lot of these problems can come from. But our goal, our mission as providers should be to prevent and alleviate the dysphoria. You know, so how do we do that, right? And what they talk a lot about is this concept of affirmation, which is a word we've heard a few times already this evening. But I just want to talk a little bit more about exactly what that means. Affirmation is a more current word than transition. Transition implies you're helping this person to become a new person, whereas affirmation implies I'm helping you to be yourself. You don't have to change. You know, I'm helping you to live as the person you really are and have always been. And that difference can be very important because, as many people have alluded to already tonight, we shouldn't necessarily make assumptions that this person has to seek hormone therapy or have surgery or change their name legally to feel affirmed, you know, in who they are. That's something for that person to decide for themselves. But the term affirmation is referring to helping you be who you are and live as your true self. So the question is, how can we as providers do that? Because for many of us, we're not necessarily going to be the people who are providing that specialized care for gender diverse youth. You know, not all of us in this room are going to be prescribing hormones or, you know, doing surgery or things like that, right? But there's still a big role we can play. And the first thing that you need to start with is the fact that so many gender expansive youth are afraid to see their doctor, are afraid to see a doctor or any kind of healthcare provider because they're afraid of being judged or mistreated. So if they're not even comfortable coming to our door, like how the hell are we supposed to begin, right? And so that's kind of what this guideline really spends time talking about, is how can we make these kids comfortable enough to see us so we can actually open some conversation and maybe get them then to the specialist who can help them further. Now, the article offers some pretty good tips, and I have a few as well, just from personal experience that I wanted to share, and it would be great if other people have found things that work for them that they can share with the group. But a few things is just when I'm saying hello to someone, and you know, and a lot of the time, like with you, like I'm coming in cold. I don't necessarily know that this person has a diverse gender identity, but I walk in and I say, "Hi, I'm Dr. Kumar. What's your name?" right? And I think that kind of gives them an opening for them to introduce themselves as they want to. I think that another thing that's helpful to talk about that we haven't really talked about up to this point is the physical environment. So it is really helpful to have flyers or posters around your office that have relevance to LGBTQ issues, so that you're really setting up that my clinic is a place for all kids and teenagers to get healthcare and to get help. It can also be helpful to have like little symbols, like the little triangle stickers and things like that you can have there, so that people know like this is a space. I cannot emphasize enough the importance of having a single stall, all gender restroom available in your practices. That is an incredibly, it's simple and yet an incredibly important thing that you can do to make your patients feel more comfortable. Names and pronouns as given by your patient should be specifically incorporated into medical charts and easily visible by all staff. And for those of you who accept Medicaid or Medicare, my office sees a lot of Medi-Cal patients. This is a meaningful use requirement. So for your clinic to actually receive that meaningful use funding, you have to be compliant with those standards, which I think is very powerful. Many people have talked about the importance of staff training. One thing that I often do, because in my clinic, unfortunately, I don't have a consistent medical assistant. I often have, I have any one of like 4 or 5 medical assistants. And many of them are much more experienced working with babies as opposed to older kids and adolescents. So when I'm working with an MA, I try to run my list with them before my clinic starts. And if there's a kid who I know uses a name that's different than their legal name, or their gender is different than what's listed as their sex on the medical chart, because it hasn't been updated yet, then I'll try to give them a heads up ahead of time. Because I find that with a lot of the staff, if they're prepared, they really want to do their best to make people feel comfortable. I think what makes them nervous is just being caught unawares and then not having the words, you know. But I think if you give them notice ahead of time, like, this is not Catherine, this is Kevin, just so you know. You know what I mean? Like, I think that actually takes a big weight off their shoulders. And even if Kevin is just coming in for a cough, you know, they can do their part to help him to feel more comfortable. If you are in the position where you have a kid in a family actually coming to you for the first time, and it's happening in front of you, it's coming up that this child is sharing that their gender identity is different than their natal sex, or the family has just discovered this for the first time, I think there's a few things that I found helpful. The first thing is, I don't think it's necessarily fair to come in guns blazing and basically tell the parent, if you don't 100% affirm them for who they are, you're a bad parent. I don't think those should be the first words out of your mouth. I think that just as the kid is going through their process of understanding and accepting their gender identity, parents and families and friends and loved ones are going to have their process too. And I think, like Dr. Depp was saying, sometimes it's about helping translate that to each other. Sometimes I have to tell the kid, like, your mom just found out something that you've known for a really long time, but she just found out, and she might need a few minutes to catch up. Right. You know what I'm saying, right? She might need some time to kind of to understand this. And that doesn't mean that at the end of it, she's not going to get to a place where she can help you with your affirmation, right? But you need to give her a little time. Give her space to ask questions and to understand things and to voice her concern. And I think that kids are very willing then to help to educate their friends and to help get them the resources that they need. I think bringing it back to the bottom line is really important. A lot of the time, the hesitations I find that parents have is not so much that they come from a very rigid, standpoint where they're like, this is not normal, this can never be normal. It's more that they're worried about the stigma their child will face from the rest. And that's where a lot of their hesitation and concern and maybe they want more time to understand things or to help their kid go on to the next step. That's where that comes from. I think helping the kid to understand that too. Not that your mom or dad doesn't love you and accept you and wants to help you in your affirmation, but the world is not a nice place. Your parents get that and they're afraid. I had one family actually. The mother was Vietnamese. I should have sent them your way. But her concern for her, this was a slightly different case. Her son identified as gay, but her big concern was, I love him. I'm not worried about me. I'm worried about the rest of the world. I'm worried about and the rest of our community. And I don't want them to hurt him. And I think it was really helpful for her son to hear that. Like, that's what mom is worried about. It's not like she has a problem with who I am, but these are very legitimate fears that she has. But I think bringing it back to the bottom line, which is it's every parent's job to unconditionally love and accept their kid. And if you kind of use that as step one, then you can kind of build on the rest. From there, I think that really helps parents feel assured that things will be okay. As long as those fundamentals are in place. And then you're in this great position to be able to introduce concepts of gender affirmation and all the background concepts. It could be as simple as just social affirmation. So in terms of dress and hairstyle, names and pronouns that you use. It could be legal affirmation, changing your name. It could be medical affirmation with hormonal therapy, or it could be surgical affirmation. But just going to give people an idea of their options and let them know that you have the freedom to think about and explore all of them, and that you can provide referrals to appropriate specialists at the time that they're ready for them. It doesn't all have to happen tomorrow, but I think that giving them some idea of the world that's out there, the supports that they could have, then letting them kind of choose it. I think that one of the most important things we can then do as primary care providers is the adjunctive care. If I'm referring somebody to a gender specialist, one of the first things I try to do for my patients who identify as male is offer menstrual support. Because it might take a few months or years, by the time things get to the point that they are able to start blockers or cross-hormone therapy or things like that, in which case I could give them a shot of Depo-Provera right now, today, and help take their periods away. And that's at least a little bridge that I can do for them while they're waiting for specialist care. I think another thing that's really, really, really important is offering really inclusive sexual health screening. So when you're asking them about their sexual activity, to ask, who do you have sex with? What body parts do you use when you have sex? I can't tell you the number of patients I have who have penises and who have sex with either men or trans women, and they never get a rectal swab, or they never get a throat swab or anything like that. They only have the standard urine test. Like, here's your urine test. You take your urine test and you're fine. We've checked for everything. That's not true. So to really offer them that comprehensive screening, to talk to trans men while you have a cervix, you still need to get a pap test. While you have breasts, we still need to do breast exams. But to also be sensitive, not to necessarily do genital or breast exams just because. I usually only try to do them for a purpose, but I also explain the rationale for screening. And these are the things you can be doing as primary care providers to support them while they're also getting specialists. The last thing I just wanted to talk about briefly was areas of advocacy where it would be really great for more primary care providers to get involved. And a lot of this has come up this evening already, but insurance coverage. In many sort of archaic insurance definition books, gender identity and gender diversity is still categorized as a mental disorder, which means that getting medical insurance for medical treatments like hormone therapy is really, really difficult. And so that is something that, as a group, we need to keep advocating to change. I think advocating for more inclusive and safe school spaces is something where, as pediatric providers, we have a lot of influence. and we should use that influence. And then I think the last piece that is maybe one of the most frustrating is consent to treatment. That for pretty much every other reproductive health service, at least in California, for most of whatever comes up, if you're over 12, or sometimes if you're any age, you can consent to receive birth control, to receive STD or HIV testing, to receive pregnancy care, or to receive pregnancy termination services. These are all things you can consent for, but you can't consent for gender affirming care, to receive hormone therapy, without both your parents, agreeing to consent for you. And I think that that's a really serious problem, that a really important barrier that needs to be removed. So I'll stop there, but these are just some thoughts for primary care providers. Yeah.